I just thought I'll just make a brief introduction. I think Ashwin is well known to all of us who have been here for some time, but maybe not to the younger ones who have been here. He's currently professor of surgery and pediatrics at the University of Wisconsin-Madison and Marshfield Children's Hospital. Prior to this, he was at Texas Children's. He's an alumni of PGI Chandigarh and has had extensive experience in managing children with shortgut. So I thought he was the optimal person to talk about this, because this remains one of the unresolved problems in pediatric surgery, at least in our setting. Again, Ashwin is on call today, so we would hope to start and finish without prolonging things too much. So without too much ado, I'll hand over to Ashwin.
Okay. Thank you very much, Sanjay, again, and thank you for that little thing that you mentioned about the background. That background actually is from Michigan. I am doing an executive MBA with the University of Michigan, and we recently presented our project. So that's how the background comes. I forgot to change it, but it is, the wonderful university that I'm doing my executive MBA from. So with that, also saying that please excuse me if I have to interrupt in between, because I'm on call and there might be some calls that come in the. I have told everybody that I'm presenting a lecture. They should be kind enough to let me do that. But sometimes if the ER calls, I might have to. With that, I'm going to start sharing my screen since we don't have too much time. And do you see my screen?
Yeah, we can see your screen well. Yes.
Yes. Okay. Okay. So we're going to start with surgical rehabilitation. When I spoke to Sanjay, he suggested that I should be speaking more on the surgical rehabilitation in kids, and that's what I would be talking about. But as we say that we talk about surgical rehabilitation, mostly what we are doing is still talking about medical, because medical rehabilitation comes 90% of the way. Only 10% or 15% would be the surgical portions in short gut syndrome. So we cannot not talk about the medical portions without, and just be talking about the surgical rehabilitation. So I would be now starting with, the goals of, bowel rehabilitation. The most important part here is the nutritional rehabilitation, and that's where the medical management comes in. And we will talk a little bit about it, since, as I said, 90% is all that. So I'm going to speak about a little bit about the nutritional rehabilitation. And the next bit is prevention and management of the sequelae and complications. As you know, people who have managed shortcut, they all know that the complications or the sequelae or the disease itself could be overwhelming. You have heard about bacterial overgrowth. You have heard about the TPN complications or the central line complications. All these have to be dealt with along with the nutritional rehabilitation. Once all those are taken care of and you're getting good growth, that is where we consider the surgical rehabilitation, where we are at a stand. Okay, now we cannot proceed forward. The child is otherwise doing well, but now is still dependent on parental nutrition. We want to get more, androgenic nutrition in there. And so how do we do that? That's when the surgical rehabilitation comes. If you look at, sorry. If you look at the most important component of the entire short gut rehabilitation, mostly first thing is that we have to have a team approach. Without a team approach, we cannot succeed with disciplinary approach. We are all together in this clinic with the gastroenterologist, the surgeon, the GI team, with the nurse practitioner, the nutritionist, the pharmacist, the psychologist, and the social worker. Together, we are able to achieve much, much more as compared to what we can do as an individual person, because as a surgeon you're only looking at the surgical aspect, the gastroenterologist is looking towards the gastroenterological issues, but then the nutrition is necessary about looking at the TPN, calculating the calories for the kid. The pharmacist is important because they are the ones who are finally going to give the product, so they are important. A psychologist is important, a patient with short gut. Again, sorry for the interruption, I have to take the call. Okay.
Yeah, please go ahead. Yeah.
Yeah. Okay, so that's what I was saying. Like the psychologist is very important because they are also important aspect of the management. Short gut itself causes a lot of distress, not only to the child but to the family. If the child is older, then that issue comes in, but the family is distraught, and in that situation, the psychologist is essential. Also, there are patients issues who are like not completely um, like they cannot take care of themselves. Adjustments have to be taken in the household where they are staying. So in that situation, a social worker is important because they really work out the situation for the kids. So all our teams will always have a social worker. They work with us. Then now, if you say that I'm moving a little bit faster and moving into places where most important, because within 1 hour to come, to talk about this is really, really not enough. And I have to finish in 45 minutes. So I leave some time for discussion. So I'm going a little bit faster in the sense that, if you say how much bowel is lost or remaining, now this, those definitions have been there in literature from age old. Like when I remember from Peter Paul Rickham's definition was about less than 75 centimeters, but nobody mentions how you measure this cut, whether you measure in cadaveric length or whether you might measure the live bowel length. Because if you measure the live bowel length, it's like contracted bowel, and you're not giving the right measurements. But whatever is available in literature, that at 27 to 29 weeks of gestation, we have about 100 to 125 centimeters. At term, it reaches about 250 centimeters. This is just an average. It could be more than that or less than that. As I said, previous definitions mentioned less than 75 centimeters. But, 75 centimeters, according to our program, would be like, a very good amount of gut that is available for reconstruction. In the literature, the definitions of remaining bowel less than 30 or more than 38 centimeters, there is a likelihood of achieving independence from parenteral nutrition. This is what we really need. How much bowel is essential that we can get independence from parenteral nutrition? Here is 38 centimeters, but I remember kids who are like 20, 25 centimeters have been completely independent on parenteral nutrition. Similarly, remaining bowels, if it's less than 15 centimeters, the likelihood is 7%. But this has grown over the period of time, and 15 centimeters is considered to be good gut. With all the rehabilitation, the medical and surgical rehabilitation, when we do, we still have a higher chance. And the patients that we are sending to transplant have reduced drastically. Like, I'm just talking about the non-transplant management here, but if you see, we're only sending 2 to 3% of our patients now to transplant. So the number of patients going to transplant has reduced really, really drastically. Now, it also depends when you talk about, I said how much, we're just talking about the length of the bowel, length of the colon, length of the small bowel. But what we also need to know is what portion of the bowel is it. When you see that jejunal can be, if the jejunum is lost, then it can be compensated by the ileum. The loss of ileum, however, is not well tolerated because ileum is responsible for the vitamin B12, bile acid absorption, fluid absorption. Also, the ileal brake, that is when the lipids reach the small intestine, then there is a peptide YY that is released and it slows down the transition of the food downwards. That's the ileal brake. So the ileum is a very important portion of the bowel. If that is gone, then we really have a lot of problems and issues that we have to deal with. You also know that ileum has a greater capacity for adaptation that can take over the jejunal function, but not vice versa. So if jejunum is lost, is still okay. But if ileum is lost, it's not really okay. And nowadays, we also talk about the ileocecal valve and importance of it. In most of the literature, it has been reported that the ileocecal valve is essential. And if it is preserved, the outcomes are much better. Okay, the most other important thing that is we deal with, in shortcut is called as adaptation. Now, what is adaptation? Adaptation means the remaining gut has to adapt to the nutritional needs. How does it do that? It does it by increasing length, increasing diameter, the number of crypts are increased, the crypt depth is increased, the crypt length is increased. So all this is happening inside the mucosal surface lining is increasing, adapting to get maximum nutrition for the patient. But also it means that whilst it's adapting, it is overdoing it, and it becomes hugely dilated in that process. The exact mechanisms for this is not fully understood, but we know that there are certain nutrients in the lumen which are now best known stimulants for the adaptation. Citrulline, and which is like a derivative from arginine, it has shown that it is adaptation. It helps adaptation in animal models, but we have also seen in human experiments and studies that the citrulline levels correlate with the enterocyte mass. So nowadays, if it is a certain level that citrulline is in there, then we know how much is the enterocyte mass. It also tells us whether the risk of central line related infection is going to be more or less. That will be dependent on the citrulline level. It also tells you about whether the chances of the patient who is with like a severe short gut kid, they will tell us the chances whether this patient is going to get enteral autonomy or not, or is going to need parenteral nutrition continued in future. So we monitor the citrulline levels very closely when we are seeing these patients at follow-up. Also, the glutamine has shown little or no benefits on its own. But when glutamine is combined with growth hormone, it has shown to be efficacious. So it helps adaptation and it helps the bowel growth as well as the child growth during in patients with shortcut. Also, patients who receive long chain triglycerides, there is improved intestinal adaptation. We know that we've been using medium chain triglyceride like coconut oil and other stuff, but that is useful for nutritional component. It gets absorbed and it's good nutrition. But for adaptation to be improved, we need long chain triglycerides, and they have been shown to be really useful. Also, nowadays, previously we were using only soya-based oils, and the soya-based oils were not kind of the best oils for, getting the lipids, because they cause liver damage and responsible for the intestinal failure associated liver disease that I found over here. And the fish oils have come up now, which is omega-3 fatty acids, and they are supposed to be very protective. And we have, in fact, a lot of patients we put on omega-1 initially in the study that we were only approved based on individual patients because it was still in FDA and it was not approved. But now it has been approved and it is available as omega-1, and people can be used on individual patient basis. And it not only shown that it is useful for protecting from liver disease, but also improves adaptation. So with the adaptation that you see, I just want to, at the end of this slide, I'll show you some of the fatty acids that can be used. If you have it available in India, I'm sure they must be using it there as well. The other things or the other gut hormones like the GLP-2 or glucagon-like peptide, it is called. It's an enteroendocrine L cells that are located in the ileum and colon. This kind of produce the glucagon-like peptide or GLP-2. Now, this has got a very short life. That's why we have analogs like teduglutide. We have analogs like teduglutide, which is responsible, which stays longer and which can cause modest adaptation and improves the overall gut adaptation and gut length in kids with short gut syndrome. The newer ones are also now available. They are called as a glepaglutide and glutide. These are the newest analogs, and we still do not have enough data on them to say that they're going to be useful, but they are certainly improved versions, and we'll get more of them. Also, there are peptides like the peptide YY, which is helps in delayed gastric emptying and also causes the ileal break. When you, as I talked to you, that when you get lipid into the ileum produces this peptide YY and then delays the transit of the food across. So this is called as the ileal break and is very useful for patients to develop adaptation as well as for absorption of the nutrients. I would say, I was telling you that this is the kind of chart I have for the fourth generation we call as the lipid emulsion. And if you see, the fourth generation started with omega-1, which is 100% fish oil. But now new combinations have come up with coconut oil, which is the MCT, soybean, fish, and also soybean, coconut, olive oil, and fish oil together as combinations. And these are all fourth generation lipids available in the market. Mostly we have experience with omega-1, and it's like 100% fish oil, and it's really hepatoprotective. And we have recently we haven't had much of a problem with liver disease associated with these lipid emulsions. Another important topic, like coming from adaptation, I want to move fast and move on to what we call as the bacterial overgrowth or the small intestinal bacterial overgrowth. Now, in this, there is a lot of new advances that have happened. Previously, the definition of this was like more than 10 potentially pathogenic bacteria, more than 10 to the power 5 CFU per ml, which is the bacteria unit we use per high power field. And then we will talk more about this as I move forward, but the loss of bowel and dilatation of the remnant is the important thing here, because it is dilatation of the remnant causes the contractility of the bowel to not be the same, and you cannot get coaptation of the lumen. So there is peristalsis, or the migration, migration of the motor complexes that happens with the bowel motility, that is altered. That is a lot of motility in here. The third portion of the third phase of contraction is called as the MMC, or the migrating motor complexes, and that is altered when you have a dilated bowel. So these things allow these bacteria to, increase in number, and when they do that, they also translocate through the bacterial, the bowel wall, because in adaptation, what happens is the food or the nutrients stay in the bowel wall for a long time, and whatever has damaged the mucosal surfaces, allowing more permeability of the bowel, that allows the bacteria to translocate, and then they get into the central line and cause central line infections. Another important thing that has come up now, which is the microbiome. The understanding of the microbiome has increased so much And I'm going to tell you in the next few slides what microbiome does to the, in short gut, because even in normal gut, when we lose the microbiome, there is a lot of problems. So just imagine what we deal when we deal with a microbiome in the short gut. I'm going to tell you in the next few slides about microbiome. But the pathologic effects of this bacterial overgrowth, as you know, also cause bile acid deconjugation, and we lose the bile acid pools. We get oxalate stone. The calcium is a problem. There are several things that happen simultaneously in here. I don't have time to cover everything, but these pathologic effects, these bacteria cause inflammation in the wall, and they damage the absorptive surface, and that leads to translocation, as I said. Also, there is delactates in stool because of these bacteria like the lactobacillus. We keep giving probiotics. This lactobacillus increase in number, they become pathogenic by producing delactates in the stool, and the lactic then it gets absorbed and cause encephalopathy in this case. So these are things that we have to be extremely careful because we don't understand the microbiome. We cyclically keep giving antibiotics, and what damage it causes to the patient, we don't know, have that data. So if you look at the microbiome, what does this microbiome mean? The human gene, genome is one thing that we know about, but the microbiome is the second genome that we have. It has got like 3 million bacteria in our gut. And the function of this gut bacteria, the human microbiome, is modulates the central nervous system, immune system development, protection against diseases, metabolism, vitamin synthesis, digestion, absorption. All these functions are done by the human microbiome. And we are not even aware of what we are doing to the microbiome by destroying the gut microbiome using antibiotics. Here, what does it cause? When you give antibiotics, it causes dysbiosis. The dysbiosis is basically caused because of the dietary changes that we do, the genetics changes, the stress, the antibiotics. Antibiotics is an important component, and that causes dysbiosis and leads to disease. But in short gut, what does it do? When you are using cyclical neomycin, kanamycin, all those kinds of antibiotics that we give these patients without a thought, there is a recent article published in fact, 2021 in the Gut Microbes, and it has studied about the short gut syndrome. What it is showing is an antibiotic-driven intestinal dysbiosis that we're causing. We're causing a change in the normal microbiome with persistent, giving of antibiotics, and the gut-derived bloodstream infections, which we thought we are preventing by giving these cyclical antibiotics, maybe we are causing dysbiosis, we are causing bacteria which should not have been there to colonize that area and give rise to more line infection. So this is only initial studies right now, but more about microbiome will tell us what we are doing. The microbiome, we only know about probiotics, but now we have the prebiotics, probiotics, and postbiotics. What is prebiotic? Prebiotics is the stuff or the medication or the stuff that we can give to the patient along with the probiotics. Now, these are nutrients for the good bacteria, so that we want to keep the good bacteria growing, and we want to not allow the bad bacteria from going. So what we do, we starve the bad bacteria and we give food to the good bacteria. That is the prebiotics. The postbiotics are just the bacterial products, like, the products the bacteria produce to give their action. We can directly give these postbiotics. So a combination of these therapies are now available, and we can use those in our treatment of, short gut. As I said, medical management is the most important, and I cannot not cover it, but I have tried to give a brief idea about what the medical management would be. Like, we start with, if we have a very small gut, we usually use a G tube for a titration of enteral feed. It's not essential, but it really helps because oral feeds the kid may take, may not take. NG tubes cannot be kept for long, so we use gastrostomy tube to titrate the feed. We start with a parenteral nutrition using a tunnel central line. when we see that we can start the feeds, we do a slow introduction and advancement of the feeds. Whilst the kid is on partial enteral, partial PN, then we do regular electrolytes and mineral levels to make sure that we are doing the correct replacement for the kids. Traffic feeds are essential, as everybody knows that traffic fields are essential for intestinal adaptation and also for the colonic mucosal cells, also for the bacteria to move forward, the contractility of the bowel. All this is essential. So traffic feeds are very essential. And even if you can give 3 ml, 4 ml, whatever continuous feeds, that is useful in these patients. As I said, continuous feeds are better than bolus. Why? Because there is not enough gut and we want to improve the transit time. And since we want to give a good transit time, we use continuous feed. But as soon as we can switch to bolus feeds, because they are more physiological, we switch to those feeds. And as I said, gastrostomy tube is necessary, not in all patients, but it is useful for long-term enteral intake. Also, we use fish oil-based lipid solution to prevent IFAL or the liver disease that is originating from that. So once you take care of all the factors, you have a multidisciplinary team, then we decide about the indications of the bowel lengthening. Okay, there are no fixed criteria here, which patient will go for bowel lengthening, which will not. It is decided based on an individual patient. It's customized to the patient. So when you see, okay, we are doing everything good, but there is no further progress on enteral intake, and we have reached the maximum medical support we can give the child, then is the time to consider the bowel lengthening. If you start seeing signs of intestinal failure related liver disease, then yes, that is the time to go for bowel lengthening, and maybe we can take care of the gut that way. Also, if you have patients on full enteral feeds, but the gut is extremely dilated and the patient is getting repeated infection with bacterial translocation because of bacterial overgrowth, that is another indication where we can reduce the dilated bowel by doing whatever endogenous reconstruction. Usually, it's good to have a bowel diameter more than 4 centimeters because we have to, at least for good function, have a bowel diameter of 2 centimeters. So if we want to lengthen this bowel, and if it is not even 4 centimeters, so we can give a lumen of at least 2 centimeters. So usually most people would like the bowel diameter to be 4 centimeters. We can always do a little bit cheating with 3.8, 3.5, but usually 4 centimeters is what is a good bowel diameter to consider for lengthening. Now, there are different methods of lengthening, but everything has now come to just this step procedure. And previously, the age-old described Bianchi procedure, we all know it is the longitudinal lengthening versus the serial transverse enteroplasty or the step procedure. I'm going to take few steps on these. And then the new technique that has been described is the spiral intestinal lengthening and tailoring. I'll tell you about that. But again, very few studies, very few reports. The major procedure nowadays most people are doing is the step procedure. The other ones like the distractant enterogenesis and tissue engineering are still in experimental stages. So you all know, I mean, this has been there for like ages that Bianchi described, I think in the 80s, that this procedure for bowel lengthening. The thing is, it is not a simple procedure for everybody to do. I mean, it is easily possible to do, but if you have had no experience of doing it, then it's very difficult for some people to imagine. So what we are doing is basically the bowel, which is, say dilated 4 centimeters, you split it in the center and you keep the blood supply from the 2 vasa to each segment. You can see that as the blood supply reaches the bowel, it splits into 2 to go on either side. You take advantage of that and split the bowel into 2. And that's how you get doubling of the length. The large study that you see was on 20 years and with 19 patients. Not many people are doing the Bianchi procedure anymore. Only few patients are being reported. So, there are not many large studies with the Bianchi procedure. With whatever we have, they found that the mean length of surgery was this much, and then the mean age at surgery was 1.62 years. Of the 16 patients that they did this approach, 8 responded to Bianchi. That means they were able to get patients on complete enteral nutrition with 8 patients, but they had almost more than 50% of the patients they needed transplant. Again, this data is a bit old, and as I said, not many people are still doing Bianchi, so it's hard to obtain new data on this approach. There are 4 patients who died, and 1 after transplant, and 3 still on TPN. This is old data. Everything has improved. I don't think the multidisciplinary approaches were in vogue that time, but now the multidisciplinary approach has really the medical management, and a lot of new drugs and treatments that are available have changed this a lot. So with the step procedure, the next one is the step procedure, which we all know is called as the serial transverse endoplasty. Now it is based on, a dilated bowel. And then we use the stapler to reduce the dilated bowel in a stepwise manner. So what basically you're doing is you're cutting with the stapler on either side to leave a constant length. So as you see, we need at least 4 centimeters to get a 2 centimeter channel. So you're using the endo-GIA on either side, and we're making a little window in the bowel mesentery, and then we're cutting on both sides. At least 2 centimeter channel is needed, so we can have the length about 2 centimeter here and the distance about 2 centimeters. So that way we are able to get a 2 centimeter tunnel, lumen of the bowel. If the bowel diameter is more than that, certainly we can get more lengths of bowel with this. Whereas with the Bianchi, we can only get double the size of what we have. Here, we can get much more depending on how much is the diameter. So you see, this is one of my patients. We had like very little bowel left, and you can see that this portion is hugely dilated, and this is mostly jejunum that we are seeing over here. And we also had some portion of the colon, but not all of it. But at the jejunocolic anastomosis, this is narrow. And then so we now did a nice length, and we got significant length in this patient by doing the step procedure. We have run close to 16, 17 patients. Not many patients need the procedure. As I said, only 10% are needing. So this procedure is really useful. In fact, I have gone and demonstrated this procedure in several parts of different countries. Like I have done some in India too. One of my patients that I did in I think it was in Goa, where it's now almost close to 10 years old, not 10 years, maybe 5 years. I forget the exact age, but she did really well. She's on complete enteral nutrition, not needing any TPN anymore. So, even internationally, this has been successful in giving good outcomes with good bowel management programs. As I said, 16 patients, what we got was the mean increase in bowel length about 91 centimeters. Mean decrease in bowel diameter was 70 millimeters. There was significant increase in weight and height that we obtained. We were able to transition the 6 patients off TPN within almost a median of 248 days. 2 patients were referred that time for transplant, and 3 patients had GI bleed and catheter-related bacterial infections were fine. But this is like a smaller study of ours. There are more bigger studies, which is a meta-analysis. Now we discuss a little bit about the meta-analysis that for the step procedure. In fact, in this meta-analysis, they had like 16 studies included, a total of 180 pediatric patients. They also had adult and mixed patients, but I'm only considering the pediatric patient. The average age is 2 months to 5 years. And the small bowel remnant was about 18 to 26 centimeters as a median, and the range was about 10 to 145 centimeters. Even the median is in a range here because it's a meta-analysis. And an IC valve that was preserved in 23%, and it was very important, turned out to be a very important factor in patients with shotgun. The pre-step bowel length was about 29 to 107 centimeters. The pre-step bowel diameter, as mentioned, in about 50% of the studies, they mentioned it about 4 to 6 centimeters. The more the diameter, as you know, we can lengthen it more. The median follow-up was by about 5 months to 3.9 years. Now, 3.9 years is a pretty good range to have a follow-up. That will be if they have been on, enteral nutrition for that period of time, and that is really awesome. Again, increase in the short bowel length. Patients who had the small bowel, the length that was increased was by 42 to 100%. So you can see that the step procedure, even during the first step procedure, you can get a length about 45 to 100% in most series. And the etiologies you can see on this picture, I mean, intestinal atresia were about 35%, gastroschisis 29%, and the other ones like NEC is like only 20%. Volvulus, Hirschsprung's, and others are very, very small component of this. Maximum is still intestinal atresia, not the usual one, but most of these intestinal atresia would be the type 3Bs with apple peel and apple core atresia. Those are the ones we're talking about. Then from the same meta-analysis, what we found was there were post-operative complications with like GI bleed. In fact, in 132 patients, they had no complications. GI bleed 7, staple line leak few, 6 patients. So the number of complications were really minimal. The no complication group is huge. Also, if you're looking at enteral autonomy over here, how many children got complete enteral autonomy? Now, this is a meta-analysis. Whenever you have a meta-analysis, you have to take advantages of the meta-analysis, but you have to take it with a pinch of salt because this is being studied throughout the world. What is the situation there? What kind of resources we have? We do not know. So whatever is mentioned in literature, you take. In fact, our enteral autonomy is almost 60 to 70%. In our kids. Also, when we take enteral autonomy with the TPN, another 10 to 20% patients are on enteral first TPN still doing extremely well. Again, here they're mentioning still dependent on parenteral nutrition. Now we don't know how much they're partial or how much we have only a little 10% of the patient having some parenteral nutrition. So it's like with a pinch of salt, we have to take all this data. So it may not match exactly with the best centers performing this procedure. So with the 36%, I would say for us, it is like only 20%. Again, here, there is another criteria mentioned about re-steps. So there are people also performing re-step. Also, we perform re-steps, and there's 17.22% patients who needed a re-step, and they did well after the re-steps. And look at the amount of transplantation. The entire world is sending only 6.11% to transplantation. And as I said, our rate is only 2 to 3%, where we can send only 2 to 3% patients for transplantation. The mortality is only 5.55. Again, meta-analysis mortality is high. Our mortality is 1 to 2%. Again, very based on central line infections, or maybe no gut left at all, or waiting for transplantation is when we get these mortalities. And this is the data for re-step. If you look at the yellow bars, this is the first time step. And then there are several studies here showing that patients have had a re-step. The blue marking is for the re-step. So re-step is also getting good results. In fact, 31 patients we have of all the reported literature. And there are so many people performing this procedure but not reporting, and so many papers not being accepted as well. So whatever been accepted, whatever is in the literature, we have like 31 patients who had a re-step procedure in the studies that been reported. Now we're talking about controlled bowel expansion. This has come up with the thought that we need dilated gut for, short gut lengthening. We need a dilated bowel so that we can lengthen. So there are some people using this technique of controlled bowel expansion where they create a stoma and a catheterizable stoma, so that the catheter with a balloon is used in the stoma, and they use increasing times of obstruction to the lumen so that we can get dilatation. Again, this has to be very carefully controlled. It has to be on the floor where people are managing, because the complications can happen with this, because if you are not paying attention, you can have perforations of the bowel, or a lot of vomiting and other issues can happen. So it has to be in a controlled environment. There are some studies that report success with this, that they get able to get dilatation of the bowel for lengthening. And then whatever comes out as from this, they recycle it, because recycling is important. Otherwise, you get colonic atrophy, which is not good for short gut. There's another technique that they have been describing, which we call as the spiral intestinal lengthening or tailoring technique. And again, these involves, cutting the bowel in a certain way and then joining it. The only problem with this technique I have seen, I mean, there's not much reports on it. This is a new technique and only one or two papers are on it. Maybe only the primary author has reported this. So they have to cut the bowel, and it is like the contamination it's not stapled. So everything is cut and resewn. So putting it inside and doing, it's a little bit more comprehensive and causes more chances of leaks and maybe more chances of infection. But since we don't have the data to corroborate this, so we will just leave it as an experimental procedure for the time being till we have more data. But it has been used on humans. There are one or two papers which mention about this technique. Now, if you compare the longitudinal technique with the step technique, that step can be performed on any length of bowel. It can be performed on the proximal jejunum or the duodenum as well, because we can mobilize it and we are able to do the stepping over there. Whereas in, the longitudinal, once it is done, we cannot do a redo, whereas we can do a redo step. Even after a previous step or a previous longitudinal lengthening, we can still do a step. So step does have some advantages. Advantage also is that more the dilatation with the step, the more better it is. With the longitudinal lengthening, we can only double the length, but with the step, we can attain much more length, because the bigger the dilatation, if you create a 2 centimeter channel, and if we have a 6 centimeter dilated bowel, then it becomes 3 times almost the length that we can achieve with the step. So step has advantages. Nowadays, more things are coming out about step, saying that it interrupts the circular lumen, right? When we're doing multiple cuts on the bowel on either side, we are interrupting the circular muscle. And that's why we are getting more and more dilated bowel even after the first step procedure. So it has advantages, but people have seen a lot of dilatation happening even after the step. A redo step has helped in, as I said, the re-step data has been mentioned there. That is helping. So these kind of procedures are not 100%, and we still have to be, able to get, under a multidisciplinary approach to watch these patients over a prolonged period of time. What we are able to achieve, though, is because we increase the length, these patients can be watched over a period of time, and they can be prevented from going for transplant. Though the complications of this procedure and the outcomes reported afterwards have still been not 100%, there is still a lot of morbidity. If you speak to the families, if you speak to the patients, a lot of care and involvement from the families is essential. So it is not a procedure that we can say, okay, once we are done, we have enteral and autonomy and we are done. It's not, because as they grow, they need, this defecation in multiple times. They are still defecating. They have flatulence. They are still getting some infections here and there. So it's not absolutely 100%, but it's much better than going for a transplant for sure. There are some experimental interesting procedures that are being done as well, like, distraction enterogenesis, which is how we obtain, bowel length by distraction. Then mechanical stretching of the bowel. You can, use isolated segment of the bowel and use a distraction device that can lengthen the mucosal mass and cause epithelial proliferation. Some of the examples of this, you can see there are 2 balloons up here, and they put the 2 balloons inside the intestine, and then they distract. The 2 balloons, once you distract, where there is a spring, pushing the 2 balloons apart will cause distraction. The other technique is they have a spring which is loaded in a dissolvable capsule that dissolves once it is put inside, and again you put it in the intestine, and once it dissolves slowly, the spring comes out, causes distraction. This is called a distraction enterogenesis. In fact, there is a recent paper on it. Again, it's still experimental, and it's causing about distraction enterogenesis in the murine colon, and it was in Journal of Pediatric Surgery in 2022. So more more data is available on this. I don't have too much time. I think it's closing to 45 minutes and I have to finish, so I will not be able to go in details about distraction and angiogenesis. We also have tissue engineering techniques for the small intestine, which we can use the host intestine, and you can use scaffolds. We can get up to 3 times length from the human organoids that have been used. You can get up to 3 centimeters, 4 centimeters segments. That are still not enough, and more stuff is needed before we can use tissue engineering as our only choice for gut lengthening. These are some pictures showing about the how we can use the organoids, like either the colonoid organoids or the epithelial organoids, to develop, to get the bowel lengthening. In conclusion, as I said, team approach is the most important. Fish oil provides a lot of advantages because it prevents liver disease. It's hepatoprotective. Teduglutide and other newer glutides have been very useful and showing promising results. Bowel restriction may help in lengthening in bowel in future. We still have to have the right device to lengthen the bowel, and tissue engineering may also come up and help us get segments of the bowel. With that, I would say we finished almost 47 minutes, and I had completed within the time limit allotted so that I can leave some time for questions. Thank you very much, Sanjay, for this opportunity, and I'm open to any questions that anybody may have.
Ashwin, thank you very much for taking time out and doing this very exhaustive presentation. I think you have covered a lot of ground, and I think it is also opened avenues for people to follow up and read if it is something that they are interested in. Can I just request you to stop sharing the screen so we can see each other?
Sure.
There are a couple of questions on the chat box. So one of them is, so they say, at what point would you consider stopping TPN in children, which, when you're going to operate these patients and things, when do they, because your average time is some 250 odd days in that meta-analysis. So what time would they stop the TPN? 100% nutrition, 70% nutrition?
So there is, as I said, it has to be individualized to the patient. Now, if we have patients who are getting enteral nutrition and TPN, we initially start with TPN and then gradually introduce, the enteral nutrition. As we keep on advancing and we see that we are getting good progress, like if I'm able to get 1 or 2 ml every month of increasing enteral nutrition, then I am encouraged and I will continue to go till complete enteral autonomy is obtained. Only this technique. If at a point where we are stuck and for several months we are not advancing the enteral nutrition, and we are thinking that only we will have a point like after 3-4 months we are stuck, we just can't advance. As soon as we advance, we get diarrhea or high outputs, and that's the time when we decide, okay, now we have to take this patient maybe to go for lengthening procedures. So these are again individualized to patients. Maybe there is something else happening. So we have to look at all the criteria that we discussed before we decide to take the patient to surgery. Surgery is not my first goal. My first goal is to get enteral independence as much as possible on its own before even trying surgery. And as I said, most patients, we are able to get this before getting to surgery, 80% to 90%, but just by enteral, just by this multidisciplinary approach, we're able to get to that point. And then in 10% where we are like really stuck, we use surgeries to get beyond. And only 2 to 3% patients are going for transplant nowadays.
There's another question. I think the challenge that we face here, as you are well aware, is basically maintaining long-term TPN. That continues to remain a challenge, I think, both from a point of the resources that need to be allocated to care for that child, and whatever other additional expertise is required to maintain these patients on TPN long-term. I mean, most units are using short-term TPN, but to maintain children for hundreds of days on TPN is not something that is readily available. So the question is, with this kind of setup, obviously the ideal thing to do would be to build all these ancillary services and be able to raise resources and look after these children with TPN for prolonged periods of time. But what else can be done if you have a child with short gut in our kind of setting that you're familiar with? What options do we have?
Okay, So that's a very, very good question, Sanjay. And I always mention when I go on these, trips to different countries that you should always not just base on whatever Western literature is available. You should base on whatever resources that are available to you. So if I was in Ethiopia, it's going to be different. If I was in Tunisia, it's going to be different. And when I'm in India, it's going to be different. The reason being that the resources are different in different. Now, if you say, can you give some TPN? Can you give some omega-1? It depends on that. So every situation, if say Sanjay is in a very good institute in India, maybe you can in your place give some TPN, maybe you can give omega-1 in that situation. But there might be another extreme situation where we have a kid with short gut syndrome, but we do not have any TPN, we have only NFO. Okay, the best approach for that situation would be putting in a G tube or a jejunostomy or a Foley catheter into the stomach and gradually increasing the enteral nutrition. Now, you might say that we do not have any TPN, how is this kid going to survive for long term? In that patient, if you already have dilatation and if you can lengthen the gut, go ahead and lengthen the gut. But if you don't have dilatation, you cannot even do that. So in that situation, without TPN, it's going to be extremely difficult. Then I do not have a solution to that. But if we have a bowel that is dilated, go ahead and perform the lengthening procedure in advance because you have no other choice. I usually wait up to the age of 1 year for the dilatation to happen, and then subsequently we can do the dilatation. But you have to cater based on the resources that you have.
So what's the imaging that you use to assess all this? Is it ultrasound? Is it cross-sectional imaging? How do you actually make these assessments?
So the assessment that we make, first of all, we will have some assessment based on what the surgeon reported when he did the surgery. That would be the initial. Then subsequently, we use either contrast studies that we do follow through contrast studies, or we do CT with contrast to make sure that we know how much length. Our radiologist we have been talking to always, we tell them like how we want the bowel measured, and then they very carefully, when they do the contrast study, give us an approximate length based on the cine radiography that they do on this patient. It's very approximate. It is not very close to. We have tried to get studies where we see when we open the patient and we try to measure the length versus the radiological length. It does correlate a little bit, but it's not against 100% correlate because you're looking at the peristalsis, you're looking and measuring at the bowel in that way. Whereas when you have the bowel in hand, you pull the bowel, you use pieces of thread, all the ways that we use during surgery to measure the length. So they are still very approximate. It's not 100% that we will be having the exact length of the bowel. Some idea after looking at several contrast studies with the radiologist, you get to idea, okay, this much is going from this point to this much, the transit time is this much, how much colon is remaining, we can see the colon characteristics in there, is the anastomosis open or not, is there a narrowing, is something holding up, is there mechanical obstruction to it, are there adhesions and kinks and stuff like that can be known on MRI also, as well as the contrast studies and CT contrast.
Thank you. Couple of more questions. One, it says, why is transplantation? What are the challenges with small bowel transplantation, and why is it, why are increasingly patients not being sent there, you try to avoid doing small bowel transplant as much as possible. So why is it not as popular as other solid organ transplantation is the question.
Yeah. So the problem with small bowel transplant, I have worked with small bowel transplant when I was in Birmingham for a long period of time. The issue with small bowel is that it is a lymphatic organ, and because it has got lymphatics in it, the chances of rejection are extremely high. Though the success rate has improved significantly with that, but the complications and morbidity of transplant in the bowel is still very high. The liver transplant outcomes are really good, but we have, as you know, we have to do liver and small bowel because of the liver disease associated with it. And then when we do that, the bowel itself causing complications of leakages, narrowing, strictures, anastomotic problems is very high. It has come down, as I'm saying, but we still would like to preserve our own gut and be not immunosuppressed with those medications. That's the advantage, and that's why we want to prevent from going to small bowel transplant.
Thank you. I think one more question, Dr. Salim. Dr. Salim is a colleague of ours who's currently in Qatar. He says we have an intestinal rehabilitation center at Sidra Medical. We are doing a lot of tube stomas and controlled tissue expansions. We have about 11 patients of this. How is your experience with ultra short gut, ultra short type of short bowel? I guess that's what the question he's asking. Yeah.
Yeah, so ultra short, again, as I said, definitions are different in different places. I don't know what he means by ultra short, but I'm thinking he's meaning less than 20 centimeters or less than 15 centimeters. Even with those patients, we never had to do too many ostomies and gut expansions and stuff like that. Even with those, we will use the same technique of bowel rehabilitation. We go through the rehabilitation program and we continue to manage them based on TP and enteral nutrition. Get to maximum enteral nutrition as possible. And when we come to the point where we cannot advance any further, we will try to do the gut lengthening procedures. There is very few patients, as I said, that are not being able to salvage by this technique.
Ashwin, thank you. I think that's the questions that I have on the chat box. I will open it. We have another 2-3 minutes. If somebody wants to make a comment, Dr. Bagdi, would you, you had posted something earlier on. Would you come on and
Welcome to Apollo Children's Hospital, so I just want to greet you.
Okay. Any other questions? Any other observations from anybody? Please feel free to unmute and speak. If there's nothing much there, then no, we will call it a day and let Ashwin get on with his day's activities. I mean, his day is starting while we are winding down. Well, I guess Ashwin, that's what there is here. I don't have any more questions. So I think we are in time, and thank you very much for taking time off, on a morning when you're on call and thank you very much. And this will be available on, it is available for people to watch on our YouTube and for people to see. And I'm sure if there is any questions, they will reach out to you. So thank you very much again, and all the best. And you're traveling again, I think, in a couple of weeks here. So we will touch base when you're here. Thanks very much, Ashwin. Thank you very much. And thank you for all the participants.
Thank you very much, Sanjay. And as I said, if anybody has any questions, I say it's an exhaustive topic, they can directly communicate with me and I'm happy to answer their questions. I'm going to be in India in next week with my mission. So hope to see some of my colleagues down there.
Thank you very much.
Bye-bye, and thank you.
I will share your email in our WhatsApp groups, if that is all right. Is that okay?
Yeah, that's fine. That's fine. Perfectly fine.
Thanks, Ashwin. Thank you very much. And thank you, ladies and gentlemen, for joining. Good night.
Bye-bye.